Buenas tardes. Les doy la bienvenida a la conferencia Agregando Utilidad Clínica a los Reportes de Laboratorio, que va a ser dictada por el profesor Wytze Oosterhuis. El profesor Oosterhuis es químico y médico del laboratorio. Sus actividades en la IFCC y en la Federación Europea de Medicina del Laboratorio se centran en la medicina del laboratorio basada en la evidencia, guías, consultas y error total y medición de la incertidumbre. Ha presidido el grupo de la EFLM de error total y actualmente preside el grupo de trabajo de la EFLM de medicina de laboratorio centrada en el paciente. Es el presidente del Comité de Guías de Química Clínica a nivel nacional. Agradecemos al programa de la BIFCC de Abbott Visiting Lecturers por el apoyo. Profesor Oosterhuis, le agradecemos su participación en nuestro congreso. Lo dejo en uso de la palabra. Muchas gracias.
Thank you very much for inviting me. And I'm very sorry not to be actually in Uruguay, but at home where it's getting dark. And we are asked to stay at home because we have a second wave, which is worse than with you. Okay, I have been presenting about total error and measurement uncertainty, and now this is a totally different subject about adding value to reports. And that's an activity we do in our laboratory on a daily basis. So I will introduce you to that, what we have done. And we have done some research in that respect too. Okay, well, according to ISO, we should advise on examinations and we should advise on interpretation. That's linked to the central activity of the laboratory. Well, and my question is, how many consultations do you actually do on an average day? And well, the thing is, if you wait for that, it might be not that much. I heard an interesting story about drills, and maybe you heard the story that a man who was selling drills, he was asked, well, are your customers satisfied? And he said, yes, they are very satisfied. I am able to sell lots of drills. And the man said, do you really know what your customers want? And he said, yes, they want drills, a lot of them. And he said, no, they don't want drills. They want holes. They want as less as drills as possible. And they need your drills to get what they really want, and that is holes. Well, that might be a lesson for the laboratory. We provide tests, but do our customers and the doctors really want tests? They want answers to their questions. And I show you that that is really the case. So here you see some results of a male of 74 years, and he has a slight anemia. It's all normal. Oh, this is also normal, only a low AGB. The rest is normal, no deficiencies. Renal function is for that age more or less normal, at least not will not give anemia. No infection. So what could we add here? Well, one thing is that ACE inhibitors are linked to anemia because they inhibit the action of angiotensin, and that stimulates directly erythropoietin. So there is a relation between the widely used ACE inhibitors or angiotensin receptor blockers and anemia. And here's a meta-analysis of that. So that was quite new to us because we saw a lot of cases with slight anemia and like this patient with nothing abnormal except for this slight anemia. And in many cases, they use these medicines. So that is something that you could add to these reports, and we do. That's just an example. Well, is this the next one? Yes. Well, what can we do to expand our service to the clinic? And well, there has been thoughts about it for many years. And this interpretation of results and not only providing numbers has been an idea that goes around for a long time. And here you see other papers. These go back 25 years. People thinking about what is the future of clinical chemistry? And even, does clinical chemistry have a future? And again, they make a strong case for us providing more than numbers, helping doctors with interpretation, adding value to your numbers. And this author even said it may not survive. If we only provide numbers, then the discussion will be only about costs, about efficiency, about quality. But if we really want to add value and expand and develop, I'm convinced that we should move into the direction of consultation. In the Netherlands, we had a plan, a 5-year plan of our society, and that was called From Measurement to Consultation and From Chemical to Medical. And that was a very strong idea to move in that direction. If we really succeeded in the Netherlands, I have my doubt, but at least there was a will to go in that direction. And well, we developed a guideline in the Netherlands on consultation, and part of it is about this reflective testing I will talk about. But we identified certain topics for consultation. For instance, it is now in our guideline that every laboratory should provide the service of interpretation of anemia. So a general practitioner can put a single cross on his request form, ask for anemia diagnosis, and then we first at the lab measure AGB. If there's no anemia, you're ready. If there is anemia, we have a protocol of looking at iron deficiency, B12, folate, everything, renal, anemia. And then we put also on the report an interpretation. And this is a large success, at least in our laboratory. Maybe it's too much of a success because we have to make an interpretation of reports every day of about 30 reports. So we do this on turn with my colleagues, but it is quite a job to do, 30 reports. Okay. Well, also from the European Federation, there was rather recently, a paper, and again it is that we should more engage in translating these numbers into meaning and to interpretation. So a lot of initiatives pointing in that direction. But what are the current practices? Because, well, waiting for your telephone to ring, I think is not an option. And I think certain colleagues very well achieve a position within the hospital, and they are well known and they are respected, and doctors know to find them. But maybe we should look for a standardized way for this consultation, and not a way that is based on very individual qualities. It should be a sort of standard, that in my view. So I thought this is an interesting study from, these are all general practitioners. And they, this one, it was a thesis from this Huben, he's called, he is a general practitioner. And he said, how do general practitioners work with laboratory results? And he found out that if these results fit into the hypothesis of the general practitioner, they use the results when it is in their line of thought. But when it's unexpected, when these results are not fitting into their hypothesis, they tend to discard these results, pay no attention. So they stay within in their area of their knowledge. But if something is outside, then they don't act upon it. And that's relates to where we can help. We can help them with things that they don't know. I'm focused on general practitioners now because that's the area where we can most help the doctors. So we do a lot of reflex testing, and I think that will be in your lab too. If TSH is abnormal, you can automatically add free T4. If calcium is low, you can look for vitamin deficiency. Potassium or calcium low, you may add magnesium. And if you have low hemoglobin, you can look further for the reason behind that. But what is reflective testing? The term reflective is that the reflection is by the laboratory specialist. He is reflecting on the results using his brains and add tests when necessary and uses evidence-based algorithms, guidelines as much as possible, and add comments to the physician. That's the whole idea. So it's a lot of action asked from us. It takes time. Well, these both activities are complementary. If in this paper they say, well, if it's a simple activity, you can use reflex testing, but as soon as it becomes a little bit more complicated, you need a medical specialist, a laboratory specialist to look at this and give an interpretation. So I can give you some examples. You have here a male patient of 53 years old, and there is an abnormal bilirubin, and all the rest is normal. So this is not so well known by general practitioners. Well, we might recognize this as, well, we first want to exclude hemolysis. If you have another sample, you could add reticulocyte count. You exclude hemolysis as is done here. And then you say, well, it's a benign high bilirubin. That's hereditary Gilbert syndrome, as we call it. 6% of people have it, at least in Europe. Clinically not relevant or almost not relevant. And you might repeat this test for confirmation. And you can do DNA analysis, but it's seldom indicated. So that's something that could help the general practitioner. Actually, general practitioners might refer this patient to a surgeon or internal medicine if they don't understand it. So who has started this reflective testing? That was by Peterson and Peterson. 16 years ago, they introduced this term, reflective testing, and they gave an example of iron studies. 17,000 reports went through their computer system, I think, or their hands, and they selected only 150 for adding on tests, based on a high ferritin or high transaminases. They found 28 cases of iron saturation, high iron saturation, and at last they had 8 patients with hereditary hemochromatosis. So what do you need to implement this in practice? We have a very simple filter in our laboratory information system. You cannot go through all the reports. We have between 500 and 1,000 reports a day from general practitioners, so that is way too much. We have a filter based only on extreme values and delta check. It's not rocket science. It can easily be set into your laboratory information system. What is more complicated is that you should filter out the reports for general practitioners. So that's what we do, and then we have a list every day of about up to 100 cases that we have to evaluate. I have here another example of a man of 44 years old, low hemoglobin and very low MCV, and well, it's I think a little bit more rare in the Netherlands than in South America. But if you exclude iron deficiency here with high normal ferritin, then it's very, it could be a case of thalassemia or other hemoglobinopathy. And we could advise to do hemoglobin electrophoresis. It's not an exception that these cases are treated with iron by general practitioners who don't recognize this case. And so it was actually done, and well, you recognize a high hemoglobin A2, that is, you prove beta thalassemia with that, and a high hemoglobin, fetal hemoglobin can be elevated in that case too. So that was confirmed. I have another example here. This is what we see on a very regular basis. High liver enzymes, high ferritin. You can exclude iron hemochromatosis, but it's not here, but that's what I regularly do. You see a low HDL cholesterol, high triglycerides. You might have an elevated glucose. You might have high urate. Well, this is the pattern of metabolic syndrome. So then the comment is this patient overweight? Might be a case of fatty liver disease. General practitioners are warned because this is not rare. It's very frequent. If the patient has diabetes, 80% have fatty liver disease. This is the pattern that you see, and you might consider an echo, how you call it, that's done here. Ultrasound, I must say, and steatosis was confirmed. This is what we see very regularly. So it's so how do these general practitioners appreciate this service? Well, we just started this. This is already a long time ago. We just started this without discussion. It was a little bit rude, but I thought, well, let's just find out and see what happens. So we started this, adding tests, adding comments, and it might as well have been that these general practitioners said, well, what are you interfering with our patients? Go away. we don't need this. And what I did then was take reports, print them out, the reports with reflective testing, with the comments on it, print them on paper, send them back to the general practitioner, and only ask them to put on one number between 1 and 10 if they liked it or not. That was the only thing. And the average number was about 7.5. So at least we had a little confirmation that general practitioners liked this service and we could continue. They were not angry. So we did a better questionnaire after that and go more into in depth if it affected their management and so on. So the second questionnaire, we took 200 reports, sent them back to the general practitioners, and asked how did it influence your patient management? Well, this questionnaire was published in a Dutch paper, and this was the questionnaire, so it was quite lengthy, and this was our report at that time. You see and I marked the extra tests that were added were marked. And here's the comment, and here's the questionnaire. So they sent them back, and these are the results. So these are a little bit old, but I think still valid. And they said, well, positive was a positive effect, influence on patient management in more than half of the cases. A quicker, faster diagnosis, faster reference to the specialist, adjustment of medication, etc. There were about half, they said it was did not affect management, but it was useful in almost all of the cases, at least to know. And there was only one that was negative. It was a low sodium, and in that case it was suspected of water retention in heart failure, and the patient was sent to the cardiologist for ultrasound, and decompensation, heart failure was not confirmed. So it's not that bad. Nothing happened, nothing bad happened, but you see an overwhelmingly positive response. So the conclusion was it is appreciated, and in majority of cases it leads to an improvement, at least in the opinion of general practitioners. This is all very subjective, of course. So we thought this is an improvement of our quality. So we did another study, and we said, well, we sent some clinical scenarios to see in what are the cases that we are more of help and what are cases that we are not so much of help. And at the same time, there was another study from the UK, so we adapted our study a little bit so it could be compared. And we invented these scenarios. So these were not real patients, it were just invented cases. And we asked, what do you want us to do? To add tests, to confirm the situation, to phone you, to add a comment, or do nothing, as we do most of the cases, and only report the numbers. And these are, I will not go into all of them, but the idea is that there are some cases that are very simple. If you have a lipemic sample, well, it is not bad to see if test for the lipid profile. If there's anemia with high MCV, it's not a bad idea to add folic acid and B12, vitamin B12. But there are other cases that we would not do. This is a little bit over the limit. If you have a very young girl with low FSH, for what reason it is measured, I don't know, but to add HG to see if she is pregnant. We would not do that without a telephone call. And the same for a woman of 40 years old, to see if also a low FSH and add HG. We would not do this again, but we just added it to see where is about the limit that we could go with adding these tests. Well, these are our results, and you see add tests is not a problem in most of the cases. That's what is preferred in most of the cases. And indeed, adding this AGG, this pregnancy test, is something that we should phone the doctor for. But that is more or less expected. In all other cases, adding of tests, adding commands is preferred. And in all the cases, do nothing and only report the results. What is our routine is the least appreciated. So that is the drill and whole story. They want us to command and they want us to help them with information. There is a large need out there for more information, and it's what we not do. You see here the results from the study from the UK, and it's more or less the same. You also see here pregnancy test is should be first, the doctor should be phoned. And this is quite remarkable because here the reflective testing was much more and longer a routine than with us. And well, UK has a little bit different system, and yet we've found the same results, very comparable. So that was a confirmation of this. Another thing is, do general practitioners learn from us? And we were able to show this too. They do learn from this activity. There was another town in the Netherlands, and well, we were talking with them, and they wanted also to start this reflective testing. So we had done it for a couple of years, and we wrote a paper, a syllabus with all examples of reflective testing they could use. And we thought that it would be interesting to see how general practitioners reacted on cases and if they were comparable. They were not comparable. These are, again, hypothetical cases that we gave them only the laboratory results, and we asked them to make a diagnosis or an interpretation of these results. Here again is the Gilbert syndrome. So the general practitioner received laboratory results with an isolated high bilirubin, and so on. Hemochromatosis, high ferritin with high iron saturation. Alcohol abuse, high MCV, high triglycerides, high liver enzymes, and so on. So, M protein is also interesting. High ESR with no other abnormalities, and a normal CRP. So this is us, and this is the other town, other hospital lab for general practitioners, and you see that almost every case we have a higher percentage of correct interpretation. And you see some cases, Gilbert syndrome, is 2 times higher correctly identified. Hemochromatosis, that's not that seldom. You have hereditary hemochromatosis, but you have more cases of secondary hemochromatosis, like in alcohol abuse or liver disease. So also twice as much recognized correctly by our general practitioners. So, and this is even a level of significance here. And here, hemochromatosis, Gilbert syndrome, and that might be because they are less, they're more frequent. M protein, you see, this is very, very badly recognized by general practitioners. That's something they don't know. Thalassemia is not so bad. I had expected it lower. So you see alcohol abuse, they don't recognize. So this was for us very interesting that there was such a large difference of factor 2 in recognizing these abnormalities. So the present study, we just did another study, and that is the last one, to see if we really could find an effect in patient management, because we are not interested so much in the opinion of general practitioners. We want to see a really hard evidence of a clinical effect. So we had some funding for that too. And what we did was, we had an intervention group that received the results, added tests and comments, and a control group that received only the ordered tests. This was very complicated to achieve because we treated the patients completely the same. So first, the reflective testing was done, the comments were added, and then we had a randomization step, and half of the patients received the results, and the other half did not receive additional test results and comments. We had to do something with the laboratory system to achieve this, and to hold up these comments and not report them to them. So we had a follow-up of 6 months. It is now accepted for publication. So these are the general numbers. We see about 500 reports a day. These are tested. 65 at that period, 65 were evaluated. About 13, 14 reports a day were subject to reflective testing, and about 3 tests were added on each case. So these reports, these patient data were evaluated by a team, and this is the team. It's one from internal medicine. This is a general practitioner from university, and this is a clinical chemist that was independent. And it was scored if these comments were useful or not, as in their opinion at least. If the intentions of the general practitioner we made a distinction between intentions and actions, because a lot of times the general practitioners wrote in their medical documents, retest thyroid, repeat thyroid tests in 3 months. That's correct in that case, but it was not done. We could not find the results. So then there was a positive intention, but for some reason, we don't know, it was not done. So we had a lot of reports, and that was a lot of work to go through them and score them. 350 reports. There were 270 with comments, 80 test added but no comments because it was not so very interesting, or a negative case was confirmed. And in the majority of cases, at least the scoring team thought these were useful, and in 3 cases not useful. So these were the results, and you see this is the intention of general practitioners. You see that the control group who did not receive our comments, and these are the intervention group, these received the reflective testing. You see they are significantly better treatment. We don't know the outcome of the treatment, but we know that the treatment that the general practitioner decided was considered better compared with or following the guidelines, for instance. And this is the actual improvement in what they did. So it is a huge improvement in what they actually did. So they did the retesting, they did the ultrasound, etc., what was advised. So we think this is the first outcome study of reflective testing, and it is just accepted for publication in Annals of Clinical Biochemistry of the UK. We also made a website of this, and with our friends in Argentina, it has been translated in Spanish. So if you visit it, you see Spanish examples of reflective testing and commenting. So I come to the end of my lecture, a little bit early, I see, but we think that it's firmly proven that general practitioners appreciate this service highly. I can add this, that we are now in a merging situation. We have merged about 4 years ago in our region. So we did this service first in the laboratory I worked, and now it's merged with another hospital, and the general practitioners there actually asked for this service last year. They heard from the general practitioners of the other hospital, and they actively asked for this service. So we started this also for them. Another thing that is asked very frequently: how can you possibly give a comment on laboratory results if you don't see the patient? Well, it can be done. I had a general practitioner that was very critical, and after a time he said, well, okay, he was convinced it could be done. He said it could be done a little bit better, but it could be done. The idea is that you should be very careful not to make conclusions that you cannot make based on limited data. But you can, with theory testing, you can very easily make a conclusion. You know why it's requested, you see the results. If you should have also historical results, you see a trend, and you can make your conclusion. And it depends. If you have a high ESR or tests that are not very linked to one disease, you should be very careful with your commenting. But it can be done. Well, this is what we proved with this study, and that's my conclusion, that we were able to show that the treatment is improved. Next thing is to show that the patient actually gets better, but at least we proved the treatment was more in line with guidelines and, well, considered by medical specialists to be better. So, I thank you for your attention. I hope you might think over to go that direction in your laboratory.
Muchas gracias, profesor. Una excelente disertación,
Okay.
muy clara. Tenemos una pregunta
Okay.
de la audiencia, que bueno, la traduje, es de Eric. Espero que haya quedado bien traducido. ¿Sería posible crear una guía de clasificación para saber cuándo debemos agregar o excluir una prueba? ¿Es mejor si tuviéramos la historia clínica del paciente o un diagnóstico probable? Hay veces en las que hay situaciones específicas en las que hay una razón para seguir con lo que solicitó el médico clínico.
Yes. Maybe this is what you mean. We have a way of supporting general practitioners in requesting tests. And we have a list in the Netherlands of possible diagnoses. And every diagnosis has a reason for requesting tests has a code. So in about half of the cases, we have this code from the general practitioner. A code can, for instance, be follow-up of treatment of thyroid disease. So if you have that code, you know it's not a new disease of the thyroid. We have a code for a 3 months checkup of diabetes. We have a code for diagnosis of anemia that we use to do anemia diagnosis. So in half of the cases, we know the problem of the general practitioner. And we have the possibility in the lab to look into the medical data of patients, at least if they have visited the hospital. And in most cases they have. So I think in at most 20% of the cases, I have to look into the medical data and see if this patient is known for something to make a correct interpretation. Yes, maybe that answers your question.
Muchas gracias, profesor, nuevamente por su excelente exposición. Queda bien en evidencia de la importancia justamente de agregar valor a los reportes del laboratorio, que realmente podemos aportar bastante. Le agradezco nuevamente su participación, agradecemos también a la IFCC, gracias a su programa de Visiting Lecturer, y a la audiencia les recordamos que les va a llegar una encuesta vía mail para que respondan sobre la participación en esta conferencia del doctor Oosterhuis. Muchas gracias a todos y buenas tardes.